Okay, good evening everyone. We will get started. My name's Helen Wood. I'll be moderating the session this evening and would just like to welcome everyone to the participant briefing of the PFAS health study. So obviously an opportunity tonight to hear from the study panel. We also have some senior members from the Department of Health here this evening and we're very keen obviously to share the information with you. And I will step through a few items this evening, but we are in terms of the structure of the session, looking to spend about half the evening on the presentation itself, and then the other half as a question and answer session. So we're very keen to hear from participants and our audience if you've got questions as we go. I will explain a little bit about the housekeeping around that in just a moment. So after we do the housekeeping, there's some acknowledgements that we would like to make. As I said, then into the presentation, we'll then have the Q&A session. And at the end, we'll also let you know other ways to contact the study team. So obviously very important that you can have access to the team to answer questions that we may not be able to get to tonight. We do have a large audience this evening. We are expecting around about 190 people. So we won't be able to answer all questions or hear from each of you, but we will do our best to answer as many as possible through the Q&A session and also to share the information with you this evening prior to the release of the reports. So in terms of some housekeeping, let me do that first and then we will acknowledge who we've got here with us this evening. So the chat function as normal in Zoom is available, but we would like all questions this evening to go through the Q&A section of the control board that you'll see at the bottom of your screen. So you'll see Q&A there. If you do have a question for the panel at any time, you could pop a question there. We'll be monitoring them in the background. And when we get to the Q&A session, we'll obviously draw on those questions and as many as we can in the time we have available and see how we go with that. The chat function is there and all the chat function comments will be downloaded after the session, but we would ask you if possible just to minimise use of the chat room while we're in presentation mode. It's just a little distracting both for the speakers and for all of us trying to listen to the presentation for those comments to be popping up through the session. So if you could hold on that as much as possible. We certainly don't want to restrict you too much in using that, but we just ask if during the presentations you might minimise that. Again, if you have got a question though, as you go, please pop it in the Q&A section and we'll look to filter those questions, group up any themes that are similar in the background and answer as many as we possibly can. We won't be able tonight to respond to any personal medical questions. So if you do have something that's very particular to your personal medical situation, we would really recommend that you speak to your doctor or your health professional. We won't be able to answer those questions this evening. So if we could just keep that in mind. If there are some technical questions that we're not able to answer, sort of do justice tonight quickly, we will take those on board. There is a frequently asked questions page that will be on the website and we'll be able to, all the questions from this evening will get addressed as long as they're not personal questions, they will be addressed through those FAQs after the session. So if we have to take some on notice, we will, but again, we'll look to answer as many as we possibly can. There will be other opportunities to engage with the study team and to ask questions, and they are the in-person sessions that will happen in the affected communities early next year. There will be a toll-free number, which I will leave you with as the last slide of the session, along with an email address. And again, any questions that come through tonight that we can't answer, we will put in the FAQ document. And if there's a lot of similar questions from people, we will update that document as often as possible. Sorry, just the slides having a little moment there. So let's now move into the acknowledgements. We'd like very much to acknowledge the traditional owners, particularly those relevant either to the land that we're meeting on this evening or the communities themselves. And they are the Djarawar people from the Darling Downs, Dharawal, which covers Kiama and Shell Harbour, the Warramie from Williamtown, Arunda, Alice Springs, Jarawen, Doggerman and the Waterman lands off the Katherine in the NT, the Kalano, Binjara, Rockhole communities in Katherine. And we'd also formally, as part of that, like to acknowledge the Worley, Health Service, who were very helpful in setting up the studies, and a local Aboriginal Health Service, and really thank the Board of Directors, along with particularly May Roses, who helped a lot in helping the study team set up the organisation around the study. So thank you very much to all those, and our acknowledgements to the traditional owners, past, present and emerging. We'd also, of course, importantly, like to acknowledge the participants themselves of the health study. Many of you are with us this evening, and we're obviously keen to share the results with you, which we'll move into shortly. Thank you both for your participation and also for joining us this evening. We'd also acknowledge and thank our community reference panel members, who obviously are also very helpful in terms of the study. So we also would like to let you know the release plan around the reports. So tonight, obviously, is the participant briefing, and that's about the overall summary of the results, and obviously an opportunity to answer as many questions as we can from yourselves. Tomorrow, the report will be released publicly, so it'll be available on the study website. And as I said, there'll be an opportunity to contact the study team, with questions again after this evening if you'd like to, and we'll let you know the appropriate email and phone number to use for that later in the session. And there will be face-to-face sessions in the affected communities in early next year. Now, we do have to say, subject to COVID-19 restrictions, obviously, but the plan at this stage, restrictions allowing, is that we will have face-to-face sessions in the community early next year. So tonight we have a panel with us, and the first half of the session in terms of the presentation will be conducted by Martin Kirk and Rosemary Corder. So Martin is the Principal Investigator of the PFAS Health Study and will kick off the presentation this evening. He's a Professor at the Australian National University, has conducted research into diseases transmitted by contaminated foods, wastes and environments. So very experienced and great to have you here today, Martin. Martin will be followed by Rosemary Corder. Rosemary is the Principal Investigator of the data linkage component of the health study. I'm sure she'll explain what that means when we hand over to Rosemary. She's also an Associate Professor at the ANU and works in chronic disease epidemiology and health services research. So thanks in advance to Martin and Rosemary. I'll hand to Martin in just a moment, and I will introduce the other panel members a little bit later in the evening. Thank you, Martin.
Thanks very much. I'm just going to take control of the slides. Okay, I've got the slides. All right. Okay, thank you very much, Helen. And it's really great to talk to you today about the results of the PFAS health study. I know the communities have waited patiently, and we really appreciate that. It has been a difficult couple of years with COVID and many other interruptions. So firstly, a bit of background about PFAS. PFAS are very stable chemicals that can persist in the environment and in the human body for many years. They are resistant to heat, oil, stains, grease and water, which makes them useful for many different purposes. They're found in many common items around the home, including non-stick cookware and fabric protectant. They were used as the main component of firefighting foam, particularly in the airline and defence industries, where they were used to put out fires, including regular practice exercises. So the PFAS health study studied the health experiences of people who had lived or worked in 3 areas where PFAS had contaminated the environment from firefighting activities. So the PFAS health study was conducted in 2 phases. The first phase was where we systematically reviewed the medical literature and published this report in 2017. We also, in this first phase, developed a protocol for the study, which we conducted in 4 parts. So with the first study we did was a focus group discussion to understand the experiences of people living in these communities. The report of this is available on our website. Secondly, we conducted a blood serum study examining levels of PFAS in blood and markers of health. The third study was a survey of people who had their blood tested for PFAS, with questions about health and living in a PFAS management area. Finally, the 4th study was a data linkage study of health records from the past 35 years to examine whether people who lived in these towns had higher rates of disease and conditions than people not living in these areas. In this webinar tonight, we're going to describe the findings for the blood serum study, survey and data linkage study. We're going to concentrate more on what we found than how we conducted the studies, but the details are all in the final reports that we will release on our website tomorrow. So, to assess the levels of PFAS exposure in the different communities, we used blood samples collected from residents and workers in 3 communities of Williamtown, New South Wales, Oakey, Queensland and Katherine, NT, under the Australian Government-funded voluntary blood testing program. We also collected samples from randomly selected people in 3 comparison communities, which were similar to the PFAS management areas, but had no known environmental PFAS contamination. These were Kiama and Shell Harbour in New South Wales, Dalby, Queensland, and Alice Springs in the Northern Territory. We measured 9 different PFAS chemicals along with 17 markers of health, such as cholesterol and thyroid hormones. The survey asked people about 34 different health conditions, such as cancer and diabetes. We also asked them about their mental health using 4 different psychological scales. It's important to recognise that the survey relied on voluntary participation, meaning that what people reported to us may not represent the experience of the whole community. In total, 2,587 people living in exposed communities provided blood samples for testing and 917 completed a survey, as did 702 people providing blood samples from comparison communities. So what did we find? First, we answer the question, did people working and living in exposed towns have higher PFAS levels in their blood? Here we see 3 different charts showing average levels for both exposed and comparison towns in each state. The 3 bars represent the 3 main PFAS chemicals we identified in over 80% of people's blood. The gold bar represents perfluorooctane sulfonate, or PFAS. The red bar shows perfluorohexane sulfonate, or PFHXS. And the blue bar shows perfluorooctanoic acid, or PFOA. We detected each of these chemicals in blood from people in exposed and comparison communities. But you can see they're quite different. Average levels of PFOS and PFHXS were 2 to 6 tonnes higher in people living in exposed towns compared to comparison towns, while PFOA levels were similar amongst people from exposed and comparison towns. This can be explained by what was used in the firefighting foams in Australia, which mainly contained PFOS and PFHXS. The levels we saw of PFOS and PFHXS in exposed communities were similar to communities in the United States that were also affected by environmental contamination from firefighting foams. So what were the main reasons people had high levels of PFAS in their blood? Through the survey, we asked people about potential exposures before they were aware of PFAS contamination in their town. When we combined the survey and the blood testing results, we found different risk factors for having high PFAS blood levels in residents and workers in each town. On this slide, you can see the main risk factors for people having higher blood levels. In Katherine, it was living in the area for many years. In Oakey, it was using bore water at home. In Williamtown, it was eating locally grown foods, living in the area for many years and using firefighting foams at work. However, many people from the exposed communities reported that they changed how much they used bore water or ate locally grown foods once they knew about the PFAS contamination. We asked people in the survey about whether they'd experienced various different diseases. When we combined the PFAS blood levels and the information in the survey, we found that most of the health conditions were not associated with high levels of PFAS. We did find that high levels of PFAS in people's blood was associated with high levels of blood cholesterol in Williamtown. However, the increases in cholesterol were small and unlikely to be important from a clinical point of view, which is consistent with what other studies have found internationally. We found no association with self-reported heart disease. In Williamtown and Katherine, higher PFAS levels were also associated with slightly elevated uric acid, which is a marker of kidney disease, but we did not see the same association for other markers of kidney disease. In the survey, higher blood levels of PFOA were associated with self-reported gout and kidney disease in Williamtown and Katherine. For all of these links, it's important to note that these differences were small and unlikely to be important for health, and that we saw little consistency across the exposed communities. We looked at many other health conditions, including cancer, liver and thyroid disease. In the survey, very few cancers were reported overall. People in exposed communities reported more cancer than people in the comparison communities, but we found that higher PFAS level in blood were not associated with more cancer cases. There was also no clear association between PFAS levels in blood and liver and thyroid function in both of the studies. The survey did highlight the mental health impacts of living in these exposed towns. We found much higher distress and worry in all exposed communities than for people living in comparison communities. People who reported using firefighting foams at work reported high levels of distress and worry. Here we have a quote from one of the participants. This is consistent with the findings of our focus group study. And the quote reads, "My main concern is the long-term health of the people who are well above the average PFAS content in their blood. And the second main concern is the mental health of the people that have been subjected to extreme pressure, not only of the blood tests, but also of their property values and lifestyle." I'm now going to hand over to Associate Professor Rosemary Corder, and she will detail the findings of the data linkage study.
Thanks, Martin. We'll just give Rosemary a moment to connect.
Oh, thank you.
Great. Thanks, Rosemary.
Yeah, thanks, Martin, and thanks, Helen. Yes, so I'm going to spend a bit of time talking about the data linkage study. Now, we'll talk through the methods a little bit more because it is a bit mysterious for people that aren't familiar with these types of studies. So the main idea of the data linkage study was to look at whether there was a link between if you've ever lived in a PFAS management area and health. And it's different to the health survey in many ways. So as you just heard from the health survey, that involved volunteers who are either currently living or working in either Katherine, Oakey or Williamtown. So it clearly doesn't include most people who have ever lived in these areas. Also, the surveys rely on self-reporting of your current health and what you've got right now at the time of your survey. And it's not you can't from surveys get a clear indication, the timeline of how conditions develop over time. So the value of linked data is that you can use by linking up historical address records with historical records on health, we can actually get a better idea of the course of diseases or health outcomes developing over time. The other important thing is that because there are official records that are collected, such as cancer records and death records, they're collected really on everybody in the population. So we could capture most of these health outcomes, or the ones that were in the records, we can capture them for most people that have ever lived in these areas for as far back as the records go. So for some of the outcomes, we had records going back to the late, to the early 1980s, really. So we actually had a long period of time where we could see outcomes that might have developed in people living in these areas. It's really important too that we also had, so our main thing here with the survey, again, the difference is with the survey, they were looking at blood samples for PFAS exposure. Here we're referring to people who exposed as anyone who's really lived in any of these communities in Katherine, Oakey or Williamtown. Importantly, is we have to compare these rates of diseases or other health conditions. So we had comparison populations. And again, we used different areas that we used in the survey data, but we did use a number of about 25 different postcodes. So there are areas that were similar to the PFAS areas, but obviously that were areas that had not been known to be contaminated with PFAS. And as I mentioned, we used officially recorded outcomes. So that's another difference, is that we weren't relying on self-report, relying on outcomes that are reported in historical records. I'll just spend a little bit of time going through a bit more detail about the actual linkage. And I'm just seeing, see whether I've got control of the slide. Doesn't seem to be. I'll try.
Rosemary, if you just click on the slide and then arrow down, you should be right.
Thank you, Helen. Right. Yeah, so this is what the data linkage looks like. Again, in the report, there are many more details for those who would like to see the detail behind this study. But essentially the way it works is we have a database of addresses in the PFAS managing areas, so Katherine, Williamtown and Oakey, and we have a list of addresses in the comparison areas. Those addresses are linked to addresses in the Medicare database. So as you know, most people in Australia are enrolled in Medicare, and they have a list of addresses for all the people that have ever enrolled. And those addresses go back to 1984. So by linking those two address lists, we can create a study population where we can separate out people who have lived in the PFAS areas, which we call in technical jargon exposed populations, and we can separate them out from people in the comparison populations. So that's our study population. Then we link to health databases. So the health databases I was referring to before, and essentially we looked at 4 different health databases. The first one was perinatal data. So this is collected by states. So Northern Territory, Queensland and New South Wales have their own perinatal data collections. And that includes data on women in their pregnancy. So things like whether they got high blood pressure in their pregnancy. And then it also has records on all the births in those states. So it records things like whether birth weights, for instance, in babies. The second lot of data we looked at was developmental data. This is data that's collected in a census that's done on children in their first year of school. And it's collected about every 3 years. And the teachers record development in 5 aspects of development in children that first year. So altogether there was 5 things we looked at in development. We had 15 outcomes maternal. The next database we looked at was cancers. So cancers are registered in Australia, all cancers are registered. And we looked at 23 different groups of cancers. And the last thing we looked at was death records. And we looked at 4 specific causes of death. That was death due to liver disease, death due to kidney disease, stroke or heart disease. So putting that all together, we actually looked at 48 different health conditions across all 3 areas. So we looked at them separately in each area. So putting that together, we looked at 144 different sets of analyses of outcomes. So now going on to the results, what did we find? Well, across those health outcomes, we did find higher rates for some health conditions among people who were living in the PFAS areas. So first of all, the birth outcomes and the maternal outcomes. In Williamtown, we found that women had higher rates of heavy bleeding after childbirth, and there were higher rates of high blood pressure during pregnancy. In Oakey, although again, the number of stillbirths was very low over the period of data that we had, which was actually for this was only back to about 2006, we did find higher rates of stillbirth in Oakey when you compared it to its comparison populations. For the developmental vulnerability scores, we found no differences in Williamtown and in Katherine with their comparison populations, but in Oakey, in 2 of the 5 areas, we did find that children were more likely to be assessed as vulnerable than their comparisons. So that was on physical health and wellbeing, and that was on language and general knowledge. Sorry, communication skills and general knowledge. In the area of cancer, we found in Katherine that prostate cancer rates were higher in Katherine than their comparison populations. In Oakey, we saw higher rates of laryngeal cancer. And in Williamtown, we saw higher rates of kidney cancer and lung cancer. And finally, for the 4 deaths we looked at, we found higher rates of coronary heart disease in Oakey and Williamtown. So you can see from all those outcomes, that was the one where we saw it across 2 different towns, whereas the other findings, we saw them in 1 of the 3 towns. Should note for all the other outcomes, so the 132, I think, other outcomes that aren't on that list, we either found no evidence of meaningful differences in the rates between the people living in the PFAS areas in a comparison, or we just didn't have enough data to draw conclusions, because some of the outcomes are rare and you don't have enough numbers to actually be confident that there really is a difference or not. So keeping that in mind, I think that there really are some important considerations in a type of study like this. It's important as an epidemiological study. It's what we call an observational study. We observe these rates. It's not an experiment. And so while we have high rates for some conditions in the PFAS areas, it doesn't necessarily mean that PFAS was the cause. There are other things we have to consider when we're thinking about this. An important one in these types of studies is that you can't what we call control for other risk factors. So, for example, if you think about something like smoking, cancer, we saw high rates of laryngeal cancer, of lung cancer, and kidney cancer. What we don't know is in the PFAS communities and the comparison communities, what the smoking rates were. So you can't be confident that, for instance, in Oakey, that just by chance people were more likely to smoke in Oakey and compared to the comparison. So you can't rule out that the differences we're seeing aren't related to smoking or indeed many other factors. The other thing to keep in mind is that we did look at a lot of outcomes, 144. And there is, in any study, there's a chance that you will find higher rates that are not related to PFAS. It could be just by chance that you found a higher rate. We don't know, but the more outcomes you look at, the more likely you will at least see some findings that could have occurred by chance. The other thing to keep in mind is that, again, as we saw for heart disease, we saw it in 2 towns, increased rates of death from heart disease. For all the other outcomes, we didn't see a consistent pattern across the towns. We saw a finding in 1 town, but not in the other 2 towns. I guess finally, when we put all this together, and again, you'll see a lot more detail in this on the report, we do put in the context of prior evidence. And apart from high blood pressure in pregnancy and kidney cancer, we really don't have any evidence for the previous evidence from all the many studies that have been done before of links between PFAS and the other outcomes that I've highlighted on the previous slide. So where are we at putting all this together before we go on to thank the study team and go on to questions? The main summary points around the health findings is that there was clear evidence that there are higher PFAS levels in Katherine, Oakey and Williamtown, and that the levels that were elevated for PFAS and PFHXS are actually the chemicals that are most found in firefighting foams. So it's consistent with expectation. It also was consistent with what they found in US studies in similar communities, the levels. We also saw clear evidence of mental health impacts, and that was from the focus groups, from people discussing these impacts, and clearly from people assessing psychological distress. We saw clear differences in the PFAS communities. For most of the health outcomes we looked at, we didn't have evidence to show a link with PFAS levels, blood levels, or living in PFAS areas. Of course, we did see some links, but they were rarely present in more than 1 community. I think taking this all together, it clearly shows a need to support communities affected by environmental PFAS. It's really important that these concerns are addressed. We also think that the study, again, like any study, it contributes to the evidence. You can never make conclusions on one particular study, but we hope that the data that we present will provide further evidence on some of the potential links between PFAS and health. Before I hand back to Helen, I'd like to really thank the health study team. Although Martin and I've done the talking today, it really has been a massive effort from these team members. Susan Trevena has been incredible in managing the study. from woe to go, and many of you will have talked or communicated with Sue over the time. Nina, Sadie and Kayla have been absolutely core players in the team, and you'll see when the reports come up that they lead the authorship of these reports. They've done a lot of the work on the analysis and the writing, and really I think we can't thank them enough. Behind all this is a huge team of epidemiologists, biostatisticians, public health experts, toxicologists from the ANU, from Curtin University, from Central Queensland University, University of Sydney, and University of Queensland. So again, we thank all the study team. So I'd like to hand back now to Helen.
Great, thanks Rosemary, and thanks Martin. Obviously, as both presenters said, there will be a lot more information in the reports which will be available tomorrow for you to look at more closely, but we are keen now to have a Q&A session and give you an opportunity to ask some questions. So we have about 75 people online at the moment. So there's a Q&A button at the bottom of your screen there. Please feel free to type in a question and we'll look to answer as many as we possibly can. So again, thank you, Rosemary and Martin. Now, both Rosemary and Martin are going to be joined by 3 other panellists tonight in terms of our QA. And let me just introduce them briefly. So Dr. Ruth Vine. Ruth is Australia's first Deputy Chief Medical Officer for Mental Health, and obviously that's come up quite strongly in the presentation this evening. And Ruth has been Victoria's Chief Psychiatrist and Director for Mental Health. Dr. Sonia Bennett is the Deputy Chief Medical Officer, who is a GP and a public health physician of 30 years experience, both in Queensland Health, the Australian Defence Force, and across academia for many years. Dr. Gary Lum, Principal Medical Advisor. Many of you would have met Gary at different stages in community, as you might have some of the other panellists. Gary joined the Department of Health in 2007 and leads to head up the Health Emergency Management Branch and is now the Principal Medical Officer. His focus is national security and health protection. So again, please submit your questions. We'll be managing those as best we can. And there's a couple, quite a few coming through already, so I'm going to go to those now. I would just remind everyone, the Q&A is where the questions will be. If you do happen to pop something in the chat, we will download that, and if there are questions in there, we will update the FAQ document on the website in the coming days. So let me start with a question for Martin. Martin, what are the findings pertaining to defence personnel in particular living on the base, particularly in Oakey? Have you got any thoughts on that for us?
Thanks very much, Helen. So we didn't specifically focus in on defence personnel. So the study was actually conducted, and obviously there's many Defence Force personnel and their families that were picked up in the study, around about 30% in the blood serum study. And so we don't have findings specific to them, but as you can see, working with firefighting foams was associated with high levels of PFAS in the blood. In terms of the specific townships, I think the reports will give more details, but there's nothing specific. And in fact, Oakey was a town where we had fewer participants than the other study areas. I think probably that we were trying to capture the general population, and it wasn't really designed as a study of Defence Force personnel, which have very different risk factors and profiles.
Mm-hmm. Okay, great. Thank you, Martin. Let me go to Ruth now. So Dr. Vine, how will the government support the mental health of people in PFAS affected communities?
Yeah, thank you very much, Helen. I mean, first, I know there were some specific supports that were put in place around, over the past several years that have now finished. In fact, the uptake of those was pretty variable. And I think what needs to be recognised is that other mental health supports, probably particularly in the COVID context, but just in general, recognising people's levels of psychological distress, are the sort of universal services that are available. And those are both through better access and sessions funded through MBS, but also through digital platforms like Head to Health, and as well as a range of number of helplines for all ages, the Kids Helpline, the Beyond Blue, and for those in crisis, suicide callback and other lines. So there, I think it's really important that people do know that supports are available, and they're available both, as I said, through your general practitioner and a mental health plan, or through those virtual or digital platforms.
All right, thank you, Ruth. Let me go to Rosemary, back to Rosemary, to talk about the data linkage study. One of our participants, Rosemary, has noted that there were only 4 death classes. Why perhaps did we not include a rare disease classification?
Yes, can you hear me all right? Am I back on?
Yes.
Yeah,
Yes.
Thank you. Sorry about that. So the first question is why we did it only looked at 4 death classes. Yeah. Okay. So a little bit more explanation of why we looked at the things we looked at in the data linkage study is obviously there is a huge number of health records, huge number of outcomes. You could look at thousands of health outcomes and it becomes a little bit pointless because again, you're going to end up with more and more things you're finding just by chance. So the way we chose what to look at is from the systematic review where people either had found possible connections before or there was some biological plausibility that you might find a link to the outcomes. So they were predetermined. We decided beforehand, these are the things that could potentially be affected by PFAS, so we'll include them. We were actually fairly over-inclusive, if anything, because we didn't want to not look at things that might be included generally. So that's why we had so many outcomes, probably more than you'd normally do in a study. In terms of the rare outcomes, it's a really good question. What you do with any study beforehand, you need to do what we call a power analysis. Say, well, if we look at this, do we have enough data to answer the question? And if you know beforehand that is so rare that you just won't have enough cases to answer the question, you can't include it in the study. So if we didn't look at it, either it was because it didn't come up in the systematic review or as being a potential link or a biologically plausible link, or it was just going to be so rare that you just can't make any conclusions. Again, even then we were over-inclusive, so we did still include quite a few conditions that were still, fairly uncommon. And you'll see from the report, it's quite hard to interpret the results of those studies because you get a lot of uncertainty around the result. So you're left saying, well, we don't know.
Okay, thanks, Rosemary. Now, there was a question earlier and someone has just put it in the chat as well. Let me go to Martin. Martin, people are asking about how the study was funded.
Yeah, thanks very much, Helen. So the study was funded through the Australian Government Department of Health, and it's funded in 2 parts. First, that part to do a systematic review of the literature and the protocols for the study, and then the second part, which was to conduct these 4 different studies.
Okay, thank you very much. So speaking of the Department of Health, let me go to Gary. So Dr. Lum, what further research will occur now, or what do you see as the next steps in relation to this particular focus on PFAS?
Yeah, thanks very much, Helen. Thanks very much for that question. And on behalf of the department, I just wanted to also say hello to everybody who's participating, and particularly those members of those communities where we visited before. In terms of research, the government's provided funding for health and medical research through the National Health and Medical Research Council's targeted call for research. And what that means is that this will help with further increase the understanding of whether there are any acute or long-term potential health effects from exposure to PFAS. So in December 2019, the NHMRC announced that there were 9 successful applications for funding, and they began work in 2019. The results are expected from those studies, usually in about 3 to 5 years from the commencement of each study. We can make available a list of the relevant studies. The earliest of those studies is expected to be reported by the end of 2023. There was a total of about $10.8 million provided for the 9 research projects. And in addition to what the Australian government has done in terms of NHMRC grant funding, the department will continue to monitor scientific research into potential health effects of PFAS and to consider new evidence to ensure that the policy advice and guidance are appropriate and support positive health outcomes. And we'll certainly update health advice and messaging as it comes along. Thanks very much, Helen.
Okay, thanks, Gary. And this might be yourself just to continue, or perhaps even Martin, but there's a couple of people in our questions thinking about the longer term and if, you know, some of the impacts might actually be experienced further down the track. So in terms of that sort of more longitudinal approach, is that kind of what you're referring to, Gary, or Martin, would you like to add anything there?
Yeah, so I think, Helen, that's a good question. I'd say two things. That one thing is that the data linkage study is longitudinal in nature. It looked at people that might have been exposed up to 35 years ago and then developed diseases later. So that is a longitudinal study. The other thing is that as one of the studies that was funded under the National Health and Medical Research Council that Gary just mentioned, there's a study at the University of Queensland, which is testing people from these communities over time. And we sent out a letter to everyone who participated in this study. If they'd like to participate in the University of Queensland, they could do that. And it's also following up. So it's following up a cohort of people in these exposed communities and a cohort of people who work as firefighters. And it's looking at the declines over time. And it has the potential to be able to look at some health effects, although it's more focusing in on what happens to levels of PFAS in the blood over time. So I think that will be quite important. We will put up details on our website about how to get in contact with that study team if people are interested in participating in that study.
All right, excellent. Thanks, Martin. Let me go to Dr. Bennett now. Sonia, a question: will the advice to local residents in the affected communities change as a result of these findings?
Thanks very much, Helen. I mean, the study has, generally the results of the study are consistent with what was known about PFAS previously. So as we've heard, it has confirmed that residents and workers in those communities can have a higher level of PFAS and seem to be associated both with drinking bore water in those areas and or consuming locally grown food, or for defence personnel using firefighting foam. So that was thought to be potentially the case before, and relevant government agencies had previously provided advice to community, which is tailored to the community around, you know, what the potential exposures to PFAS might be. So because we know that PFAS can accumulate in the blood and body, it is important that residents continue to follow that advice. And we know from the study that certainly that does seem to be the case, and you know, residents are limiting or not consuming bore water and limiting consumption of homegrown food that may be contaminated. So it's important that residents do continue to follow that advice. Local government authorities will continue to investigate sites as they have previously and provide that tailored advice, and people can find that at their find that specific advice online, either through their state or territory government authority or through the health website as well.
Okay. Thank you, Sonia. You mentioned bore water there. I have a question for Martin, particularly in relation to Williamtown and why the initial study didn't include the drinking bore water aspect at Williamtown.
Yes, thanks, Helen. So the study did actually ask about bore water consumption in Williamtown. It's just that it wasn't associated with high levels of PFAS. And you'll see in the reports tomorrow, there's a lot more detail, a lot more results. So I note that some people have put in the Q&A that a lot of the information we've presented tonight is really just a summary of the results. There will be lots of detail and numbers that people can look at when they look at the reports tomorrow on our website. It's worth noting that when the human health risk assessments were conducted in the 3 communities, Oakey had around about 45% of bore water samples above the recommended level for drinking water, and in Williamtown it was 15%. So it's probably other routes of exposure in Williamtown. And I think the key thing is that longer people have lived there, the higher the likelihood of them having higher PFAS blood levels was fairly consistent.
Okay.
And in Katherine, why we didn't see it is because the main source of exposure was the drinking water supply.
Okay. Thank you, Martin. So do keep those questions coming, everyone. We do have some time for more. I've still got a couple to go. Rosemary, back to you if I could. It's another question related to medical records and defence personnel. So the person's saying defence personnel wouldn't normally be registered in the Medicare system as defence personnel. So in terms of linkage via medical records and Medicare, was that taken into account, or does that affect sort of the conclusions around their higher levels of exposure?
Yeah, it's a really good point, and you'll see we've written about this as a limitation of the study. So in Medicare records, yeah, people who defence people who weren't registered with Medicare will not be picked up in this study. They will not be included, and it is a limitation of the use of those data.
Okay, and will those limitations, or that's an example of, they're noted in the report, I presume?
Yeah, so again, there's quite a lot of discussion around the limitations of the report, and what to keep that in mind. Some of the limitations about the interpretation of the results, and some about how much you can, what we call, generalise the results to other populations. So to some extent, we can't specifically relate this back to defence personnel.
Okay, all right, thank you. Let me now go back to Martin. You're very popular, you two, this evening. Martin, in layperson's terms, like obviously there's a lot of health professionals with us here tonight who understand, you know, the clinical kind of components of what we're talking about. But in terms of the bottom line, how would you sort of, as an overview in layperson's terms, summarise the outcome of the study?
Yes, thanks. So I think in summary, what we would say is overall, we observed higher levels of PFAS levels in blood in residents and workers of the three exposed communities. We also observed increased psychological distress in the people who in the exposed communities. I think the evidence for other adverse health outcomes was more limited. For the majority of health outcomes we studied, our findings were consistent with previous studies that haven't conclusively identified causative links between PFAS and health outcomes. And you see that we did identify some associations in the data linkage study. And it's important to recognise that in the data linkage study, we weren't using levels in blood. We were looking at whether people lived there. So if they'd ever lived there, did they have higher rates of disease than the comparison areas? And Rosemary's already gone through some of the reasons why they may or may not be associated with PFAS. We did identify an association between higher PFAS blood levels and elevated serum cholesterol, which is consistent with what we found in the systematic review. It was one of the few health conditions, and we looked at many different health conditions, where there was sufficient evidence to say that higher PFAS in the blood was associated with higher cholesterol in the blood. So we found that association as well in this study.
Okay, thank you. Jennifer, I can see that you have your hand up. If you could pop a comment in the chat or a question into the Q&A, the team will pick that up and forward that through to me. Rosemary, you've already talked about cancer and a couple of different kinds of cancer. I know personally, being in some of the affected communities a few years ago now, when we were first starting to talk about PFAS, one of the biggest concerns people had would it lead to cancer? Again, in layperson's terms, could you give us your take on really, does it cause cancer? And if so, what do we need to know about that?
Yeah, so thank you. Look, with this sort of study, you can't ever say something causes something, and you certainly can't say it about individuals. And then some people say, well, why do a study at all if you can't say anything about causation? So again, it's taking the weight of the evidence, it's putting in the context of what's come before. So this would be my summary on cancer, is yes, for some communities, we found some higher rates. Does that fit with what we found before? And So let's go through them. So laryngeal cancer, we found evidence of in one community of high rates of laryngeal cancer. We don't know if it's related to PFAS, it could be other reasons. We look at prior evidence, there's only been one other study done and they didn't find a link. Again, not to say there isn't a link, at the moment the evidence is not weighted towards there being a link. With prostate cancer, again, we found it in Katherine, we didn't find it in the other two. It could be a spurious finding, it could be real. If we look at the prior evidence on prostate cancer, there has been no studies that have shown a link, and there's been quite a few studies that have looked at this in prostate cancer. There was one subgroup that found that if you have a first degree relative, you might be more likely to get it if you're in a PFAS area, but the weight of the evidence is showing that they haven't found links. In terms of the prior evidence, we found lung cancer. There's actually no evidence, no prior evidence on lung cancer and PFAS. And with kidney cancer, the results are mixed. So we found elevated rates of kidney cancer in Williamtown, and there have been several studies looking at kidney cancer in the prior evidence, and they've been mixed. So some have found their associations with living in PFAS areas, some have found associations with elevated PFAS, and others haven't. So again, that's pointing a bit more to a mixed finding. So where does this leave us? Again, we can't say for sure. I think what's really important, again, with any of these studies is it's contributing to the weight, to the evidence. And what this will help is what will happen as other studies are rolled out, some of the ones in Australia, in other areas in the world too, this is an international issue, they start to build up. So you start to get a much better picture of what's happening with these cancers. So no one study can be definitive. And so I think that would be my summary at this stage around the cancer.
Okay, thanks, Rosemary. Martin, I have another question for you, and then I was thinking that Ruth might like to comment as well. The question is, what is the link between psychological distress, and we've noted the mental health impacts, and that's probably very understandable given the worries and concerns people have had, and high PFAS levels. So is there a connection? What is that link?
Well, it's not actually so much about the PFAS levels in blood. It's really more about the worries around the health effects, and also other things like their social circumstances, financial impacts. And we see this with lots of environmental contamination events. So similar in other situations around the country. So if houses have asbestos in them and people find it difficult to sell their house and there's potential impacts, even though they're very rare, people become very concerned, and it causes a lot of psychological distress. Mm-hmm. So there's no biological reason that PFAS in the blood causes psychological distress. It's actually more the circumstances. Mm-hmm. I'm sure Ruth would have some good comments on this as well.
Yeah, look, thanks, Martin, and thank you for the question. I mean, I think we know there are many associations of psychological distress, and they are both at a personal level, things like employment and finances and what's going on in your family, as well as at a broader community level, worrying about climate change or worrying about, the overall state of the nation and the economy. And I guess in relation to this particular study, what's been demonstrated is, again, that association between communities with more exposure to PFAS having higher levels of psychological distress than the comparator communities. But it's not, as Martin said, I think it's very unlikely to be related to the actual level of PFAS, as opposed to concerns about the other associations and some of the uncertainty that people have been talking about. And what this study adds is that other layer of both comparison between levels and between areas and between comparator levels, and also the data linkage, looking at stuff over time. And that's sort of just building on the evidence base. But I think in terms of the psychological distress, at least in part, studies like this answer some of those questions to a degree, and put to rest some of the more sort of difficult concerns around causation as opposed to association. But sadly, psychological distress is all too common in a number of communities at the moment.
Thank you, Ruth. And yes, it must be very worrying for anyone in those communities. It probably links well to a question for Dr. Lum. So Gary, how will the government, and thank you Jennifer for popping your question in, I have it here now, how will the government support the farmers and the primary producers of food where there is PFAS contamination, and thinking also around the steps involved in stopping further contamination into a broader population?
Yeah, thanks very much, Helen. And from an Australian government perspective, we'd really like to acknowledge the huge role that Australia's farmers and primary producers play. We also are aware of the concerns that are expressed by farmers and primary producers, both small scale as well as large scale in various parts of Australia, and as well as those who are living in those areas where there is PFAS contamination. From our perspective, we'd like to reassure participants, but also everybody who might see this at a later time, that Australia's got a really effective and robust food regulation system to ensure the safety of all of our food products. The Food Standards Australia and New Zealand is the regulatory or the standard setting agency for looking at things like exposure to chemical contaminants through the food. And we do know, based on the studies that are done by the scientists at FSANZ, plus all of the other work that's been done overseas, and our FSANZ colleagues are very closely aligned with similar standard-setting bodies and other bodies from other countries. And so far, the current evidence suggests that the regulation of at least the 3 main chemicals that were studied in this particular ANU EPI study, but that are also well described in the literature, and which are the main concerns for us in Australia relating to aqueous film-forming foam, that there's not really a major concern in terms of the food supply. So from that perspective, no maximum limits have been set for these PFAS chemicals in food in Australia. Having said that, I think it's important that participants appreciate that FSANZ and others also do regular work on this. So they've recently completed the 27th Australian Total Diet Study, and they had a special focus on PFAS as part of PFAS levels in the general food supply. And the study found that dietary exposure to PFAS in the general food supply is really very low. The only time when it did find any PFAS chemicals was sort of in those sort of foods that you might expect it, that you wouldn't necessarily be consuming a lot of. And of course, many of the participants will have read or seen the advice that's given around tolerable daily intakes. They're taken over a lifetime. And so if you eat, any of these particular foods occasionally, then the actual risk is probably negligible. Now, those results are going to be of interest to participants. These were foods that are found generally in supermarkets in Australia, and we anticipate that the information from that particular study will be available very shortly. I think that there might even be something in the media tomorrow.
Mm-hmm. Okay, thank you, Gary. Another question. I've just got a couple left from our participants. So just for those of you online, if you do have further questions, please pop them in the Q&A. We'll do our best to get through any more that we have, and we have got a little bit of time available. Back to Martin. Why were the risk factors for high levels different in the towns, Martin?
Thanks, Helen. So the reason we had different risk factors is really reflected the way that people were exposed. And when we look at the human health risk assessments and the environmental risk assessments, it does line up with that. So in Katherine, it was obviously through the drinking water supply, and it really relates to the length of time that people lived there. In Oakey, as I mentioned, it was drinking bore water. And so that was obviously because they've got elevated levels in the bores. And again, in Williamtown, we identified that there was duration of exposure, and I think it was eating high-risk foods. So those are foods which were identified as high risk on the risk assessment. So fruits and vegetables, livestock, eggs. So it's really reflects the different patterns of exposure. It's also important to note that for some of these towns, we didn't have as many people participate in the study, so it limits our ability to identify risk factors, and in particular in Oakey, we had far fewer people participate than in the other two towns. I should also say, and it's one thing from our perspective, we've really appreciated people's contribution to the study and what they've done, and we realise that it's been very, very difficult because it's really impacted them. So, you know, I think that we do hope that the information is useful for both communities and for government. One thing I can say is that PFAS levels in blood decline over time, and particularly where the sources of exposure have been taken away. And what we did find from the survey is that people did change their behaviour following the time that they were notified that there was PFAS in the environment. So I think that's a very good sign, and I think that study looking at PFAS levels in people's blood over time will inform that as well.
Mm-hmm. Mm-hmm. Great. All right. Well, thank you. Back to Rosemary. You talked, Rosemary, around the outcomes for pregnant women and during childbirth and etc. There's a question around whether there was any investigation or results into male fertility in the contaminated zones.
Yeah, thanks. So in terms of prior evidence, there's actually very little that we know about male fertility in PFAS. We couldn't do this, we couldn't pick that up in the data linkage study. We don't have evidence in our data sets on that. In the cross-sectional survey, they did ask about male fertility, and they didn't find an association between living in a PFAS area and male fertility.
Mm-hmm. Okay, thank you.
It's also worth noting, Helen, there is one of those NHMRC studies that Gary mentioned earlier that is specifically looking at male fertility and PFAS.
Okay, thanks, Martin. So good to note, and again, that will be available, or references to that. You'll be able to find that on the website, or indeed talk to the study team about that. Someone's asked a specific question about a recording of tonight's session, and would it be possible to have a copy? Yes, it will be possible to do that. In fact, the recording will be later tomorrow, will be on the PFAS Health Study website. It'll just need some processing time in the morning, but sometime tomorrow afternoon that will be available online, as will the full reports, and as a couple of the speakers have noted, a lot more detail. We're obviously conscious of the level of detail to get people across tonight, but we certainly wanted that summary overview in terms of what have been the key outcomes. But the 3 reports will be available on the website tomorrow and publicly released, and yes, the recording of tonight will also be there. There's a general question. I'll go to Sonia on this one. So Sonia, what is the government doing about the findings from individual towns that show that people are experiencing adverse health outcomes unlikely to be related to PFAS? So other things that have emerged.
So, I mean, it's important, Helen, to understand that a number of these health outcomes, do occur across a range of communities, and clearly we've seen higher rates of some adverse health outcomes here in this study, either associated with PFAS or not associated with PFAS, remembering that associated doesn't mean caused by, as we've just heard about, the mental health conditions as well as PFAS. So I think it's always important for people to discuss their health concerns with their doctor, so either their local GP or other healthcare provider. And we do see from time to time clusters of different diseases that seem to occur in time and space in one area. And so local authorities will always have a look at those where they seem to occur more frequently than we might expect across a community. And in this instance, it doesn't seem to me, and I take advice from Martin and Rosemary, though, that the levels would be to that extent, higher to that extent that would be needed. And so I think it's really important just for people to discuss any health concerns they have with their primary care provider.
Okay, thanks, Sonia. So we are coming to a close in terms of the questions that we have. We probably have time for 1 or 2 more. So if there's any in there, please pop them in now. Otherwise, I will start to bring the session to a close. Could I ask a general question of the panel? And this is probably, Jennifer, if you've got another question, please feel free to pop it in the Q&A. I've just noticed that you've got your hand up there. We do have a large audience tonight, which is why we haven't opened up to individual comments. A little bit hard with the sort of numbers that we have, but please pop your question in the Q&A. We'll get that as quickly as we can and refer it to the panel. So for the panel, I'll perhaps have to pick on a couple in case no one jumps in, but I guess it is a worrying thing, and people have, as we've noted, the mental health outcomes, and people have been living with or thinking about PFAS for some time now. What would you really like people to walk away with tonight? Like, what is the key takeaway, do you think? Perhaps someone from the Department of Health and someone from the study could give us some thoughts on that. So I guess what would be our key takeaway? There's lots of detail to review tomorrow, we understand that, but what would be something you would want people to take away from this evening's messages?
Helen, I might take that one initially. You know, I did see one of the early comments was that the study hadn't added value. And I guess I would say that, you know, the results are reassuring whilst they haven't confirmed anything either way. I think that in itself is reassuring, but it doesn't translate to the fact that we can then reassure people that there aren't any adverse longer term health outcomes as we've talked about with PFAS. We do know it does accumulate in the body. So I do think the results of this study are reassuring. They will inform future research. They certainly won't be forgotten, and I suspect future research questions will be tailored around the results of this and other studies as well. And in the meantime, it's, as I said before, it's just important for members of the community to understand the advice that has been provided locally about how they limit any further exposure to PFAS and change their behaviours in that way, as we heard from Martin, that people are already doing, because over time, you know, they can, if PFAS levels can decrease, and so that's probably the most important thing.
Right. All right. Thank you, Sonia. Martin or Rosemary?
Maybe I'll start and then some comments from Rosemary. Certainly from my perspective, I would like people to walk away with the knowledge that it does validate some of their of the experience of communities, certainly around psychological distress and how worrying it is for communities. The second thing is that we did identify elevated PFAS levels, and particularly those used in the firefighting foams. So, you know, from that perspective, I think that is important. One of the most, you know, I think distressing things about these chemicals is that they persist in the environment and in the human body for many years. But I think on the reassuring side, we didn't find, you know, marked health concerns from the diseases and the biomarkers we looked at. Any associations we did see, we didn't see them consistently. And the increased levels of biomarkers like cholesterol, where we did see them, they were generally very small increases. Mm-hmm. So from that perspective, I think it's reassuring. Mm-hmm. And, you know, I think it's very important to watch the research that emerges about PFAS globally. There's a huge amount of research occurring in the United States and other places, and you can be absolutely sure that the results in this study will be scrutinised and incorporated where appropriate. So just as we systematically reviewed the literature, other people will do the same with the results of this study and incorporate it into systematic reviews, and they tend to be more of a global view and are much more able to look at consistency of patterns in epidemiological studies. Mm-hmm. Rosemary, have you got anything to add?
I think that was a fair summary. Thanks, Martin.
But while I have you, Rosemary, there was a question, and Martin did refer to it earlier, but it has been asked a couple of times, so I will ask you directly. The latter part of the presentation provided only qualitative results, was sort of someone's view. Why not quantitative?
Yeah. Okay, yeah, we did toss this up and we had them in and we had them out because it just becomes a lot of numbers and can be overwhelming for a lot of people. So we decided just to report the findings in words. If you love numbers, you will get plenty of them in the report. You'll see them tomorrow. There are many, many pages and tables of numbers in there. But on that point, and again, just because of time and not being too overwhelming, it really is important when you look at the numbers too, because it's not just whether you find higher rates, what is the difference in those? And even that with some of the, most of the outcomes we have found differences in absolute terms, they weren't large differences, but they were differences. Again, not to trivialise them at all, but again, I think the numbers do help to put that in a bit of context, and seeing them all lined up against each other, I think is helpful too. But I think it just, this presentation today, it just would have been way too many numbers to present.
Yeah. And as I'll, on that note, for our participants, when we close, we'll give you the email and phone number, website, etc. And if you look at the report and you have further questions after that, there'll obviously be an opportunity to ask the panel. So just before I come to a close, there's a very specific question for Gary. Gary, could you advise where people could access the, I think it's FSANS test study?
Yeah, thanks very much for that question. It's not that intuitive because the website link is foodstandards.gov.au. So that's foodstandards.gov.au. In the media tab, so there'll be foodstandards.gov.au/media. I anticipate that probably tomorrow morning you'll find something there. And in addition, if you wanted to use the search engine and look for Australian Total Dietary Study, it'll be the 27th that'll be released.
Mm-hmm. Okay, thank you, Gary.
We'll obviously put that in the answers to questions and make that available, you know, when we put everything out later.
Great. And that's a good segue, I guess, as we start to close. We will, if we haven't answered your question this evening, it absolutely will be included in the FAQs, the frequently asked questions listing on the website. So everything that we've recorded tonight, both chat comments and the Q&A, we will look at, and wherever we can provide information or answer those questions, they'll be included in the FAQs. And as Gary said, we'll reference those websites and things that he's mentioned tonight. So I will start to close the session now, and just going on to our last slide there, Toby, if you could. It is very important that you have access to the study team for further questions once you've had a chance to digest the report. So as I said earlier, just to remind us, tomorrow the reports will be released and available on the website. So obviously tonight was for participants in particular, and very keen to give you a briefing ahead of that release. But the public report release is tomorrow. The full reports will be available on the website, and you will be able to contact the study team if you have follow-up questions. And as I said, there will be COVID restrictions allowing, but assuming that doesn't restrict us too much, there will be face-to-face consultations in each of the affected communities early next year. So there will be an opportunity to also talk to people in person about these results. And you know, we really encourage you, if you've been a participant in the study, to do that. The other options, so the telephone number there on the screen, again, a recording of this session will be released tomorrow as soon as the sort of technical end of it is resolved, probably tomorrow afternoon. Email there, which many of you probably already have, but please note it if you don't. You could take a screen capture of that if you like. And the website, obviously, you would be aware of as well. But if not, there it is, and that's where the reports will be tomorrow. We do appreciate, particularly given the comments tonight around mental health, that this is not an easy topic to discuss for people, particularly for participants and people in the affected communities directly. So we do really encourage you to seek out some support if you are feeling distressed about this evening or any of the information that we've shared. I think I'll go back to, if I could, by way of closing, the comments from our panellists about the takeaways. The data is reassuring. It does validate, though, the concerns and experience of communities in some areas, and it's really important that that's recognised and that people get across the detail of the study if that's something that they would like to do. If you're not sure about anything, as I said, please follow up the study team with additional questions. Anything tonight that was mentioned in the Q&A or the chat we will publish as a frequently asked question, and they'll be publicly available. Could I thank the panel, first of all. Thank you very much to the 5 of you this evening, and for the team behind the scenes and the broader team at ANU that has helped pull this evening together, but also obviously all of the work that's gone into the study, which is clearly quite significant. But most importantly, could I thank our participants and people who've logged in tonight, not just for this evening, obviously, but for your participation in the study. As noted, it was a volunteer activity, but it certainly, had its requirements of you as a participant, and that's very much appreciated that you're able to support the study and provide data for us, the personal data for us to utilise in the study. So thank you, everyone. I will close the webinar at that point. I do hope you found that interesting, reassuring, and if not, please follow up with additional questions of the study team after this evening. Thank you.